30, 40 minutes.
I'd like to call the Board of Commissioners meeting to order.
So call City of Jacksonville City Council to order. Go ahead and move for a motion for adoption of the.
I need a motion from the Board of Commissioners to adopt the agenda.
So moved.
I hear a second. All in favor of the motion signify by saying aye.
Aye.
Motion carries. Thank you.
Entertain a motion to adopt the agenda for tonight's meeting from Jacksonville City Council. So moved. Is there a second? Discussion? Hearing none, all in favor signify by saying aye. Aye. All opposed? Okay. So we've been brought here together today with this joint meeting to discuss the treatment alternatives for safe communities task phase 3 draft report. And we have with us Jack Charlie, am I saying that right? Charlier?
Very good.
Close enough?
Yeah, close enough, Mr. Mayor. Thank you. No.
Executive Director, Hope Fiore, Administrator and Consulting Training for Task Center for Health and Justice. And at this time, I will turn the presentation over to you.
Thank you, Mr. Mayor. Mayor Phillips, Chairman Bright, members of the Jacksonville Council and the Board of Commissioners, and all others invited, thank you so much for allowing us to be here. We do have a short presentation and then want to be open to any questions that you might ask us about the work that we have done here around treatment capacity. Let me open up then by saying my name is Jack Charlier. That's what let me move this along. Okay, there we go. My name is Jack Charlier. I'm the Executive Director of Task Center for Health and Justice. The Center for Health and Justice works with communities and jurisdictions across the United States as a nationally known nonprofit to ensure that encounters between criminal justice, law enforcement, courts, probation, parole, and those who are considered to be part of vulnerable populations, so mental health and substance use disorder, are responded to in a way that addresses the disease of addiction and the challenges of mental health, while also getting them into treatment to get them the help they need and creating safe communities. So we look at kind of the work we do around treatment capacity very much through that lens. We are, as I said, a nationally recognized nonprofit. We also do international work in this same space at the intersection of criminal justice and behavioral health. Our goal is to create safe, healthy, and just communities. Along with me here today is, as was introduced, Hope Fiore, who's one of our administrators, and will be actually doing the bulk of the presentation. Okay. When we talk about treatment capacity and the work we did here, we tend to think of it in 3 phases, 3 parts to it. First, a little bit of a couple definitions. So treatment capacity, when we say treatment, we refer to both mental health and substance use disorder drug treatment. We're using both interchangeably. Now, our work here was very much centered on the Dix Crisis Center, which is really about opiate use disorder in terms of our slice of it. But of course, we know that many of the folks who suffer from substance use disorders as well as mental health often have comorbidity or co-occurring diseases. And so while we'll talk and frame much of what we did within the opioid epidemic and the reason we were brought in here for the Dix Crisis Center, we're well aware of and include often in our recommendations the idea that these two, because they exist together, we don't separate them out. That's a false separation. It's a bifurcation that actually can damage people and also not provide the response that's needed. So when we talk about treatment, I'll use that word. Think of both drug treatment as well as mental health, but of course, again, our main focus here was the people who have opiate use disorder who are going to be moving into and out of the Dix Crisis Center. Second, when we talk about treatment capacity, it's kind of not a word that you probably have used much. Treatment capacity refers to how do you best use, how does a community or jurisdiction best use the resources you already have, and then how do you prioritize resources that you do not have. So every county, there's 3,200 counties in the United States. Every county would like to have more of everything. We work across the country. I can tell you there's not a county that wouldn't say, we want more of everything. But in the work we do, we're really looking at how do we best use your resources, and we'll explain a little bit about what does that mean. But then also, of the things that you don't have, what are the most critical for you on the investment that you've made in terms of the systems that you have built so that you get the best response. Again, people's well-being, families and children who are impacted by this, public safety, and of course, public dollars that are being spent on the services that you are providing. So if you can look on the screen, you'll see the three phases. I won't read the name of the title of each phase. Instead, I'll direct you to the question that's underneath it where it says, where are you now? Obviously, you is referring to, of course, Onslow County and the city of Jacksonville. So it's where is the city of Jacksonville and Onslow County now? That's phase one. What does the current inventory tell us about this? This is a systems approach, so we're not really concerned about individual providers or city efforts or hospital efforts. We want to know collectively together what kind of impact can you have around all the resources. Phase two, where do you want to be? So where does Onslow County and city of Jacksonville want to be? That was our work that we did around phase two. And then finally we get into phase three, which is how does Onslow County and the city of Jacksonville get to where they decided that they wanted to be. So just so understanding, and we'll go through very quickly phase one and phase two because we have presented on those already, and many of you were at the presentation we did at the Department of Public Safety a few months back around phase one and phase two. So we'll just cover that lightly. You have a full report that will give you all the information you need on that. We'll spend most of our time today, and it's not a long presentation, promise, on phase three, and then again, be open to any questions that you might have. So as I said, Hope will do quite a bit of the presentation today. She's an expert in this arena, and it's very fortunate that we have had her able to work on this project. So we'll review phases 1 and 2 to start, and then again, we'll get to phase 3. So Hope.
Thank you, Jack. So as Jack said, phase one was about understanding where are you now? What do you have now? So we took a review of what treatment capacity looks like in your community, what substance abuse treatment and what treatment providers are available and services are available. So this graphic represents the work we've done across the phases. You can see that we started with looking at who comes into the Dix Crisis Center, but that's not where the process ends. It really keeps going into the back door. After they leave the Dix Crisis Center, where do they go next? So the next doors are this bridge of case management is needed. The urgency of the opioid crisis needs a streamlined approach to connect people directly from Dix to services afterwards. Case management, which is something that we're going to be talking about throughout this process, is that bridge that connects people from Dix to services, decreasing the chances of overdose after release from Dix, and also increasing engagement in treatment. The 23-hour facility, which we will also be talking about more, is part of that continuum of care that the Dix Crisis Center and other treatment providers offer. So when we talk about treatment capacity, as Jack said, we use 3 different components to measure that. One of them is physical capacity, so taking a look at the treatment providers that exist in the community, how many people can they actually fit in their programs. Then we also looked at time to treat. So at the time of the referral to the time of the actual first initial clinical appointment, how long does that take? And finally, accessibility and availability. So when are these services offered? How can we get to them? All come into what that treatment capacity looks like. So overall, our findings from phase 1 was that there was no comprehensive and long-term process to link people with opioid use disorder at the release from the Dix Center. There are many organizations that offer components of care coordination in the community, however. And there's also a robust amount of treatment services that are already available in the community, including the 3 types of medication-assisted treatment.
Thank you. As I said, you will have, if you do not have it already, the full report on phase 1 and phase 2. This is just meant to be a very light touch so we can spend our time on phase 3. So on phase 2, the first priority that we came up with is obviously what you can see here, creating a formal warm handoff and case management process. And again, this idea of the back door out of the Dix Crisis Center to the next doors. The way to think about this is generally when we think of an episode, say a medical episode, a behavioral health intervention, I come from law enforcement, a law enforcement episode, we focus on that event itself, right? And that's where we put our attention. But in the world of recovery, whether it's recovery from drug use or from mental health, it's really kind of the longer term things that are going to make the difference. And so this back door, next door is coming out the back door, if you will, of the Dix Crisis Center to the next door, which might be in the case of drug treatment, a drug treatment facility. But then there, you go out the back door of that facility, if you will, and that's a program that might not be necessarily a building per se where you stay in. And then you go on to another door, and that other door might be a step-down program, and then you go out to another door. So just to be clear, when we talk about this, when you see that on the screen, there's a lot of next doors, there's a lot of back doors. Recovery is a process, and we're trying to get at that for you so that an investment that you have made in the individual in the Dix Crisis Center is maximized, right, and is leveraged over the long run, not just that acute incident and that acute encounter when someone is leaving the Dix Crisis Center or entering it. This priority was adopted for phase 3, so we'll say more about that. You have heard Hope say a few words on case management. We'll talk about that too, so if you can kind of just hold for 1 second, if you have any questions on that, we will get to that. Again, a visual describing what the back door, next door idea looks like. So you can see the Dix Crisis Center up here. We're not really focused on that. That's being well handled and well done. It's what comes next after that, and so that's what you see. And this is really about process. What does it look like for someone to move from back door to next door and back door to next door, and what kind of support do they get to make that happen? People and families who are even out of the crisis stage but have serious mental health issues or just mental health issues, episodic, or who have challenges with drug use, it's very hard for them to navigate the systems that for us we've created and put in place for all sorts of reasons, not least of which is that they're using drugs and they might not be thinking correctly from that standpoint, along with the other things that exist as barriers. We talk about case management. These are some of the ideas that we're going to, we have in the report that I want to make sure you understand. So you've heard us use the phrase also care coordination. Care coordination and case management are mostly interchangeable. So you might think of case management as, hey, Jack, next Tuesday at 10 a.m., go here and go to this appointment. That's not case management. Case management is what's the best thing for you to do based on who you are and what you need. Where is that? Does it make sense for you to get there? Can we get you there? How can I help get you there? Then before you go, do you need a ride? Once you get there, how did it go? Do I need to meet you there? Case management is all about supporting a person, engaging them, making sure that you are advocating for them, making sure that the systems understand kind of what resources are needed for that individual. So we're using case management and care coordination interchangeably, but I don't want you to think of case management as something light as here's an appointment, go to it, here's a piece of paper, good luck. That does not work with the populations that are coming out the back door of the Dix Crisis Center. Some of the other items that you see on here, again, I won't cover all of them. Want to make sure that the idea of case management, however, is that it's not providing treatment, and yet by the research, it's vital that in between periods where there is no treatment being delivered, someone is in recovery, is in a community, case management can still be essential to help guide, motivate, and engage that person in whatever their recovery plan is. So again, I won't talk about the rest of the items. We use case management in that sense, and it's much longer term than the treatment or intervention itself is. And that's just the way that it works out, because we need help as we go along our journey. We're not done just because we finished a treatment episode. The next priority is opening a 23-hour facility to serve as a stabilization unit. Now, unlike the Dix Crisis Center, which you've done a great job, we were here before that opened, very, very successful, and I congratulate you on that. That kind of facility, by the way, is one that the rest of the country is looking at to see which jurisdictions are doing it. National League of Cities, who we work closely with, just released a report on facilities like that. And so we're going to be bringing the work you've done to them and saying, hey, here's another one that we found. So I want to commend you on that as both Board of Commissioners and the City Council on that. We also want to put in play this idea of a 23-hour center. So if you think of the idea, right, of a continuum of care that you might need for a medical service or your car repair, right? There's a car wash, and then there's full kind of totaled car, and there's all points in between. The 23-hour facility really is kind of this idea that there are some folks for whom the RED is not appropriate, the emergency room, emergency department, for whom the crisis center is not appropriate, but taking no action, and this is a critical element, taking no action is also inappropriate, and that's what a 23-hour center, we want to make the case for that, comes in, because taking no action for certain folks who are right at that edge where it might be that a little bit of help or assistance will stop them and their families and their children. We always talk about families and children. Stop that kind of situation from deteriorating by engaging them at that point before they need the crisis center, before they need ERED, before they need jail, or before, as we say tragically, and it's the work we do, before they're found dead, before they've now committed a crime that we actually have to do something with, or you just watch their life just continue to spiral out of control and they become almost impossible to engage because they're just kind of too far along. And so the crisis center really handles part of that population, but we want to encourage the 23-hour center because that will pick up in an early preventative stage many folks in your community for whom that intervention is much better than taking no action. And we're not talking about a law enforcement intervention. This is still a treatment intervention around drug use and mental health. Again, same idea on the back door next door. So you think of the 23-hour facility. Yes, there's a back door. While people will not stay there for more than a day, they are still in need of support and guidance when they come out of there. The way to think about it is if they didn't need that, they'd probably be okay on their own. But they need that. The 23 hours is kind of like an artificial time limit, right? It's to avoid being in there for more than a day, but they will still need support. And so we use the same idea of what they'll need from a case management perspective afterwards. And with that, I will turn it back over to Hope, and we'll go a little bit longer on phase 3 and then take any questions.
Thank you. So again, phase 3 was really emphasizing how we can maximize resources that are already existing in the community and use them more efficiently. So again, we'll go back to the graphic. Meeting people at the back door of the Dix Center. How can we maintain the progress that they've made at the Dix Center and continue that on into the community? So this picture represents what the current landscape in Onslow County looks like. You can see to the left are all the points where you can enter the Dix Crisis Intervention Center. You might come in through community paramedics or the QRT program, RHA Mobile Crisis, IFS Mobile Crisis, Jacksonville Police Department, the emergency department may refer them to Dix, and then they can also come in from self-referral or family referral. Then once they're at Dix, they leave with a discharge plan, which is an appointment reminder, an appointment in the community, along with an appointment reminder within 72 hours. Depending on the provider they came into the Dix Crisis Center with, they may connect with them on the other end as well, at the back door. So community paramedics will also have a warm handoff with their clients at the back door of Dix. RHA, IFS will also, but their involvement in that process usually ends at the initial treatment appointment, which is an average of 2.5 days after release from Dix. And if they came in as a self-referral or as a drop-off from the police department or emergency department, they're leaving with no case manager. And so you can see onto the right that the length of case management then varies significantly between 0 days or upwards of 90 days if they're a community paramedic client. So highlighting that a unified system of case management would maximize the resources and again, just affirm the progress they've made at the Dix Center. As Jack was saying, case management can be used in a lot of different ways, but when we refer to case management, we find that the best definition comes from the U.S. Department of Health, Substance Abuse and Mental Health Services Administration. And so I will read this definition to you, and it's also on the screen. Per SAMHSA, case management generally can be described as a coordinated approach to the delivery of health, substance abuse, mental health, and social services, linking clients with appropriate services to address specific needs and achieve stated goals. Functions that generally comprise case management include assessment, planning, linkage, monitoring, and advocacy. So again, like Jack said, case management, care coordination can be used interchangeably, but we're talking about a much more holistic and intensive approach to case management. So we explored 4 providers in the community that are providing some sort of component of case management. We will share our recommendation on the next slide, and we know there will be questions, but we will answer those shortly. And so, again, with our concept of case management, we conceptualized it as Onslow County case management. So it's this one unified system of case management that will meet everyone at the back door of the Dix Center and connect them with treatment and community support. After looking at the existing providers in the community, we are recommending that the Community Paramedics Program be the provider for the concept of Onslow County case management. They are the closest provider in the community that are already providing this type of case management that we were talking about, just on a smaller scale. When possible, they do provide a warm handoff for their clients that are at the Dix Center. And they're well known and respected in the community by first responders as well as community providers. They're also salaried employees of the county, and they've also previously worked with peer support specialists, and this is something that the new COPE grant that you guys will be discussing later would also help to supplement with peer navigators. Our recommendation is that the Community Paramedics Program be expanded by 6 paramedics, and the case management provided will last for 1 year minimum. Right. So again, following up with the 23-hour facility. As Jack said, not all individuals will need the level of care that Dix Center provides, and Dix will not be able to accommodate all clients as well. It's an alternative to taking no action, it's an alternative to the emergency department, and it's an alternative to jail. This visual represents our the community's ideal landscape with Onslow County case management. So you can see on the left side, all of the parts are the same that are coming into Dix. But now you have 2 options. You have the 23-hour facility or the Dix Crisis Intervention Center. And again, some people may go from the 23 hours facility to the Dix Crisis Center. But regardless, they all leave and are connected to Onslow County case management. They provide case management for 1 year and are connected to treatment and services. And then they are connected with community-based peer support. Some considerations as we discuss building Onslow County case management is that this would only exist in the county, as the community paramedics are employees of Onslow County. And so a consideration would be what happens with the clients that are at the Dix Center that come from the surrounding counties. How are they connected to services? Additionally, there is not currently funding for medication-assisted treatment at the Dix Center. MAT is a standard of care for treating opioid use disorder when clinically indicated, and this is something that should be considered.
Thank you very much for allowing us this time. As I said, the written report includes much more. We wanted to keep this brief, so we are open to questions. I do want to recognize some of the people we worked with very closely, Chief Yanero, Sherry Slater, Grace Dolphy, and then Dr. Gilbert, who's not with us. We worked with many. We want to say thank you to all those we worked with. You heard the numbers. It was nearly a year's worth of work, but I want to recognize them in particular because I think they bought me a lot of Diet Coke over the last months and had a lot of conversations with them and their staff. So I want to recognize them as well as thank everybody else. And we are available for questions or whatever else the Council Board of Commissioners would like.
Mr. Lazaro.
First of all, thank you, Jack. Great report. Can you expand a little bit about the no funding for medicated assisted treatment? Because that's now, the studies have been conducted across the country how positive medicated assisted treatment has been, and why are we not getting funding for that?
Mm-hmm. So Grace, want to cue you up. This was just I just let Grace know I'm queuing her up.
I'm just wondering, I didn't realize that.
Yeah, this is just specifically to the Dix Crisis Center, and it was an observation, so Grace, if swing it your way. It is the standard of care, you're correct, and it is for the opioid use disorder population when clinically indicated, along with evidence-based manualized treatment, what should happen. So
there's kind of 2 pieces to it. The first piece being that the 23-hour facility is essential in order to provide MAT, because once you induct someone on MAT, then they no longer have the withdrawal symptoms. So someone that is seeking MAT services does not need to go to detox first. They can go directly to MAT services. So if I induct them now on our facility-based crisis side, then they no longer meet that criteria because they don't have the withdrawal symptoms. On a 23-hour side, you can get them settled, get the induction going, make sure everything goes well, and then you can move them into outpatient without having to do the entire inpatient process the way we do it now. So our Durham site has the 23-hour side and also the FBC side. And the way that they were able to make it work was that their local funder there had some block grant money, and they utilized that money and allocated the buprenorphine for MAT to the center in order to make that happen. We feel as if traditional MAT, where you have to go and pay a daily rate, is a really big barrier to our folks. Right now, we're seeing about 80% of our individuals at the Dix Center are uninsured. So us starting another MAT program like we already have in town that charges a daily rate probably will provide the same amount of barriers that we currently have. So we're hoping, and we've been looking for grant funding to be able to purchase that and move forward with MAT that way.
So you don't offer MAT even in your 7-day program?
No, because you don't need it, if that makes sense. Like you don't meet the criteria because it takes away the withdrawal symptoms because it's substituting. So you wouldn't meet criteria for the Dix Center if you're on MAT.
Thank you.
Mm-hmm.
She mentioned that the cost is prohibitive to be on MAT.
Mm-hmm.
Generally, what is that cost?
Depends on the provider, but it can run around $15 a day to receive your daily dose of MAT.
Can I throw something in on that? Is that
Yes,
okay?
of course.
So on the cost, it varies, right? Of the 3 known medications, methadone is pennies a day. It's a very effective medication. I'm not here to speak on behalf of them. I have no skin in the game. Very effective medication when clinically indicated for that person, for that right person between a doctor and a patient. And then buprenorphine, that can range $200 to $400 a month. It all depends. And then naltrexone, Vivitrol brand name, but naltrexone, that can be around $800 to $1,000 a month. Again, all 3 medications are good when clinically indicated, prescribed by a doctor, between a doctor-patient relationship. Those are all the disclaimers. But they have different costs associated with them, and I want to make that clear. The standard of practice in medication-assisted treatment is that all 3 medications are made available for a patient and a doctor to make that decision together. We do see jurisdictions that only have access to one. That's of value, to be sure, because there, for some people, the idea that that would be a good fit. But even if you were to find funding to open up one stream of a medication-assisted treatment, that would not be applicable to lots of folks, possibly. Does that make sense? They're not replaceable with each other per se. They're each doing a different thing for the right person, right patient, right time. Pregnant women, for example, cannot be on Vivitrol, right? They cannot be on naltrexone, for example. So we just want to make that clear. You don't just buy one and then, oh, we've got MAT. You want all 3 available in your community as the standard of practice.
I have a question for you. Make sure I understand this right. So when do you make the assessment? Who makes a decision to use what you're talking about, the medicines or whatever, to prohibit the symptoms that you may have, the withdrawal symptoms? I mean, is that a doctor-patient determination? Because we don't do that at the Dix Crisis Center, okay? Because ours is a triage-type center where we're trying to get them the right treatment and point them in the right direction. So who makes that determination to be the most effective treatment?
Yeah, it's between a doctor and a patient. I'm going to look at Sherry and say if in North Carolina you have a different possible arrangement with a physician's assistant or nurse practitioner. I don't know if you can do that, but it's a medical decision because it is a prescribed medication. I don't know if it's different in North Carolina in terms of others that might be able to do it also.
You have to be certified in order to provide those medications.
Yeah. Okay.
If we set up a 23-hour facility, would the operators, because Grace, you made a good point, if you're in the Dix Crisis Center, you really don't qualify or need the MAT. But if you're in the 23-hour facility, if I understand correctly, the handoff from a 23-hour facility should be the medication. And will anybody, let's say that we do set one up, I don't know that we're going to hire a official medical doctor. So how would the person exiting the 23-hour facility be referred to a medical professional who can in fact prescribe the necessary medication.
You would refer them to another outpatient provider. So for instance, the way that, and I apologize for keep referencing our Durham program, but our Durham program, the way that they have it set up is that they have, the induction starts on the 23-hour side, and then they have an outpatient opioid-based treatment program in Durham as well. And so then that gets referred to that program, and then they also have community navigators, which are peer support specialists that assist that individual during their first kind of couple weeks of OBOT, which is the shortened version of office-based opioid treatment. So it is more of a continuum of care because they're right, it has to be a fuller wraparound service because there's just too many gaps for possibilities.
One clarifying point, and this is not to correct what Grace has said. I just want to make sure it's clear that for a person who is in the Dix Crisis Center because of an opioid use disorder, so an opioid crisis, but even if not, they're there with a DSM-5 clinically diagnosed severe opioid use disorder, they, in fact, might be really, really good patients for medication-assisted treatment. What Grace is referring to, and you correct me if I'm wrong, is that if for some reason they come into the crisis center and they're stable enough to provide the medication, they will no longer meet the ability to say, you're no longer in crisis because we've now given you the medication. But that they are in need possibly of medication is probably very likely because they're in the crisis center for opioid use disorder. Does that make sense? So one is about funding and process. The other one is about, well, yes, it's possible that they need medication, and I want to be clear. It's not as if you come out of the crisis center and because of that you don't need it. You're in there, you should absolutely be reviewed for medication to assist in your process of recovery and stabilize the cravings.
So how does that differ, just for clarity, how does the Dix Crisis Center differ from detox centers that use medically assisted stabilization?
You want to speak to the crisis center first, and I'll do that.
Is it just a different designation, or we're just not authorized at our center?
So it's more so about what the individual is looking for. So for us, we provide medication-assisted treatment in the sense that we provide medications to assist with detox symptoms. And so we use a COWS score, speaking specifically to opioid use, and that determines your level of withdrawal symptoms for what medications you need in order to safely get through your withdrawals. Right. And so we use that type of medication-assisted, whereas what we're talking about is really more of like a replacement therapy where you take that.
So I guess listening to what you're saying is, talking about the parameters and the criteria for individuals to meet that particular treatment or that form of treatment. So it kind of sounds like to me, correct me if I'm wrong, it's for the more severely addicted as far as getting them the medical treatment. Because like I said, with the Dix Crisis Center, like you said, and what we're doing is we're giving them treatment, we're diagnosing them and pointing them in the right direction. But I guess the treatment for the substitute narcotics or whatever you might want, whatever you're using, like in your case, that you're talking about methadone and things of that nature, that is for the more severely addicted. Am I correct? The ones that need more long-term treatment?
It is under the diagnostic criteria called the DSM-5. They probably, people who need medication-assisted treatment of any type, and by the way, this is only for opioids. It exists for alcohol also, but not for cocaine, not for methamphetamines, just to be clear, we're in this opioid space. The people who are good candidates for the crisis center, probably, I can't say that obviously, but probably are the ones who would absolutely benefit from immediately at the back door being induced to reduce the cravings immediately. The minute that they walk out that back door, and this is not about anything that Grace and her staff in the crisis center are doing, the minute they walk out that back door, literally their brain says, you're free, you're done, go get drugs. The medications reduce that craving, stabilize that part of the brain, literally, so they can engage in treatment. So yes, the people in the crisis center are people that absolutely should be considered for medication-assisted treatment. I have no problem saying that whatsoever. I don't need to see them individually. Doesn't mean they'll all need it. Can't tell you what type they'll need, but they are there in a crisis center for opioid use disorder, absolutely. And that's the premise of the whole thing, right?
Typically, that's done in your 30-day, 60-day centers where they get you stabilized and get you on a program, I would think.
My comment is that it's personal preference. Like any treatment that you receive, medical or not, Whatever treatment you decide to go with is your personal preference based on what you're looking for. So we certainly get people that come to the center that are requesting Suboxone or methadone or what have you. And we have some folks that say, no, I don't want to take it. I've tried it before. It doesn't work for me. So while, yes, everyone could be evaluated, that's not like a guarantee that everyone would want to take that treatment route.
Then how long does it take a person to phase off the methadone or the other medication that do they become reliant on that as a replacement for the other and use physically or?
So there's no research indicating, and Sherry, you can step in if you want, there's no research indicating length, how long someone should stay on any of the medications. We don't have any kind of end time to that. The medications are doing different things in the brain, and so some of them, like naltrexone, which really is a full blocker, right? It blocks everything from going in. It is possible that people who move off that might quickly go back to using. It's kind of like a period of abstinence, whereas on buprenorphine or methadone, there is some of the opioid that's allowed to get through. So there's no good way to answer that question. There's nothing that says Jack Charlier should only be on for 8 months, and Jack Charlier is going to have 2 weeks, and then that's it. We don't have that yet. We only know that between a patient and their doctor, that they should have that conversation about, well, how are you doing? Should we step up your medication? Should we step it down? Should we try to go to a different medication? Do you want to stop altogether? And those examples abound, but there's no clinical evidence on what is the generalized path. And Sheriff, if you want to correct anything I've said, please do so. I won't be offended.
No, I was going to say, that's just, as with any medical or other condition, it's a very personal conversation between a physician, the treating physician, and the patient.
Joined with counseling at the same time, is that plays a part in it, I'm sure, as well, right? Or it's.
The research is clear that the very best outcomes for the majority of people is for opiate use disorder, that's again the space that we're in, is medication-assisted treatment along with evidence-based, I want to be clear on that, evidence-based manualized treatment. Manualized means they're following a set curriculum that includes cognitive behavioral therapies. That is the gold standard for opiate use disorder treatment. I'm going to say in the United States, but that is the gold standard for it. There are some people who will do well without treatment and just medication-assisted treatment, but that's an individual basis. There's some who might do well with just treatment. Again, evidence-based treatment, but that is not the recommended gold standard. Again, people can decline treatment or what they do. The standard of care is medication-assisted treatment if clinically indicated and the patient wants that, along with evidence-based treatment, which provides, by research, by the way, substantially better outcomes compared to anything else, substantially better. Factors of 3, 4, and 5, nowhere near not having both of those in combination.
And I would add, as we talk about medication-assisted treatment, as well as the 23-hour facility and some of the other topics that we're kind of covering here today, the important piece of it all to me is that we're talking about a continuum.
Yeah.
And different patients will need different parts of this continuum. Some will never make it into the crisis center, and, praise the Lord for that. Some will make it all the way into the crisis center to the next step and back again a time or two. And that's just what this condition, what this epidemic is about. And that's frankly why we're all sitting here today, is because it's such a big problem and such a pervasive problem. And there are so many different things needed if we're going to attack it. And Chief and I have been having this conversation for several years now. We attacked it on the training end for our first responders. We've attacked it from the crisis, facility-based crisis center. And Grace and her staff have done just a phenomenal job so far meeting our needs in the community. But we've got to attack it at many different levels and from many different angles. And so the things that we're talking about today, the medication-assisted therapy is not going to be the be-all and end-all for everyone. And there may be people that, in fact, never need it or never go on it. Just like the crisis center isn't the fix for everything, right? We've had that conversation. This is not going to fix everything. But these are things that if we put this continuum in our community together and we keep the community focused and connected in this way, we have the best outcomes for the most people. So MAT is not the answer for the problem. It is an answer. As well as the 23-hour facility and the Dix Crisis Center and the training we've done for first responders. It's all part of that continuum. It's not the answer, it's part of the answer.
That's right.
Let me ask this on funding the answer. Grace said a minute ago, and those of us who are meeting on a regular basis with the OC group, we know that about 80% of the people come there with absolutely no insurance. So a person comes with no insurance, you take care of them. They exit. They still have no insurance. So they're going to go to a doctor who wants to be paid. That becomes one of the barriers to actually getting the continuum working. So how do other communities address this issue? Because if you have no money and you have no insurance, then how do you get to step 2?
That's a never-ending question. I mean, we're talking here today, and I agree with Sherry, we're talking about, when we started proposing the Dix Crisis Center, about that it was not an end-all for everything. It's a starting point, because this is going to be an ever-growing process where everybody has to be involved, from community leaders to private sectors to doctors, whatever, because it's deeper than what we think. Because we can treat these people initially, we can direct them to the right form, to the right treatment patterns, to the right doctors or whatever, but it's going to be a continuous follow-up. And, when we had that meeting at Methodist, that's one way how we can combat that, by trying to get these people directed, trying to get them the money. That's a tough question to answer. I mean, when you don't have insurance, it's real tough. I mean, maybe the answer, and maybe I'm stepping out of line here, is to open it up to more Medicaid providers. I don't know. But that's something that we have to address continuously with this program, because we knew that the Dix Crisis Center was going to grow, and it has, and Grace and everybody has done a fantastic job, but now we have to pursue it from different angles and get everybody involved in the community awareness. So, I mean, that's a tough one to answer, though. It's a good question, though, Doctor.
But I also think that's the second step that we'll talk about in just a few minutes when we sign the MOUs and talk about the COPE grant and the peer navigators and the school portion of it that's going to help us at least prevent those things from occurring again. But I'd like to go back just to the 23-hour facility, which I thought in your report was very, very interesting. Of the 150 IVCs that you followed, you said that 75% were released within 25 hours of admission. So I think, as we had these discussions about the 16 beds and the 3 counties, and more than actually 3 counties bringing folks here, the need for capacity, that 23-hour facility is crucial to make sure that we have services available for people that are in our community. And maybe you could kind of talk about that just a little bit, of what you found.
Of the services in the community?
About the 23-hour facility and how many of the IVCs would actually benefit from that 23-hour facility.
Yeah, so like you said, approximately 75% of individuals that are involuntary committed to the emergency department leave within 25 hours. So we can assume that many of those would be potential candidates for this 23-hour facility. If they were able to go to the 23-hour facility instead of the emergency department, it would save a lot of resources, a lot of money from the emergency department, and offer an alternative for that intensive level of care.
So one of the drivers for the crisis center a couple of years ago was the number of these folks who end up in our detention center with the sheriff and his fine folks, because we simply don't know what else to do with them, or they end up in our emergency department wasting really, really scarce and valuable resources there as well. When you have someone who's clearly in some sort of crisis, and you don't have a community resource for them, they end up in one of 2 places generally, and that's either the ED or the detention center, neither of which is appropriate for folks who are in a mental health or substance use crisis. It's just not a place where their needs are really going to be met and we're going to get the outcome that we're all hoping for. So the crisis center has stepped in and filled that role and is doing a very good job at that. This is more people, another group of people, a group that may never end up at the crisis center if we can get them 3 days earlier into the 23-hour facility. And so the hope then, also having the 23-hour facility increases the capacity of the crisis center. It's never going to be more than 16 beds. That's what's allowed. So it's 16 beds, but those beds can be better utilized with the 23-hour facility available, because there are a lot of people who go through the crisis center who could be served in that 23-hour facility and stabilized and gotten, connected with the right resources, and they never have to go into the crisis center. And that leaves a bed open for that next person who really does need it.
And I also think it was important in the slide that you showed that there was a third alternative, and that was just leaving them on the street, which is,
No action,
which is an issue for our community that we've seen over and over again, is that if there's not enough to arrest them, if they don't have something medically wrong with them, they don't go to the emergency room or refuse to go to the emergency room. Really, we don't have that third option other than leaving them on the street, and that becomes progressively worse as time goes on.
Until they do fit one of those other places. Right.
Clear about how you define the difference between somebody that goes to the 23-hour facility and somebody that goes to the crisis center. What's the difference in those patients?
Sure. So there's two things to think about. The first thing being that everyone would go through the 23-hour side. So that is the true kind of front door, and that's that no wrong door. Because technically the way that the 23-hour side is set up is that it's licensed as an outpatient clinic. Whereas for the FBC side, or the Dix Crisis Intervention side, it's licensed as an inpatient clinic. And so you have to have medical necessity in order to be there in order for us to bill Medicaid. And so it's a much lower criteria, so everyone goes through, and some people won't stay 23 hours, some people will stay a few, and we're like, okay, they meet the criteria to move up a step, and they'll get moved up a step.
So it's a lower level of treatment.
Yes, sir.
If you think of it sort of like an urgent care, the 23 hours, the urgent care, the crisis center is the ED. And then when they leave the crisis center, if they can't just see their doctor next week, then they need to go into an inpatient.
It's a triage. It's
Right.
basically assessing their problem and then defining which way they
That's the
go.
continuum that we're talking about.
And in recommendations, when we do this work, you notice in the recommendations, we didn't say, build 10 treatment centers, build 5 detox centers, hire 1,000 people. We're always very realistic, mindful that you are spending public dollars, and you want to be very good stewards, as the taxpayers expect. So what we're giving you, as I open up with, is the prioritized items to maximize your bang for buck of your existing resources. Case management, which is the backbone, if you will, that connects all these other things you already have in place. You notice we didn't say expand your treatment. You need expanded treatment, but it's not the priority. The priority is case management. Priority is getting some medication-assisted treatment in because of the focus on opiate use disorder. And the priority is opening up just one more part of your continuum. Those 3 things alone will already give you more lift in terms of what you're able to do with just your existing resources. We didn't say add in all that other stuff. Just build some foundation, some framework to it, and you already will get it sorted out a little bit better for your residents and be able to say, and I respect the role that you are in, to say, hey, this is how we spent the tax dollars. Here's what we got back for that. We've got these case managers. They're reducing the number of people who are relapsing, who are coming back into ER, to the jail, or even to the crisis center, and they're staying out of these places longer too. We know that the research is very clear on how this works. It's not, it's not medical science, it's behavioral health, social science, but when done right, it does work. Treatment works when done right. So I just want to kind of make sure we frame that. We're not asking you to do everything. We're giving you prioritized recommendations that we think will maximize your return on your precious public dollars for your citizens of the county and the city.
And I think in phase 2, one of the things that you really emphasized is the fact that our community does have capacity.
Yes.
It's a matter of we're just having a gap in this service, and how we get them into that capacity to get treatment. So even though there's a number of those services that are being provided in our community, we're not getting the folks that need to be there. And I think that's the key to making sure that we maximize what we have in our community right now.
Yeah.
So Chief, thank you for that. In phase 1, when we did look at treatment capacity, overall, we found that only between 8 to 74% of treatment capacity was met. So that means of the physical capacity that your treatment providers in the community have, the maximum that they're filling up is at 74%. So again, you have that capacity in your community. And so with that case management backbone, you can connect them because it's one centralized resource that knows about the available resources in the community, has relationships with those providers, and knows how to access those services.
Let me answer this. At the end of this, we're going to have a signing ceremony between the school board, the county, and the city relative to the COPE grant. how does the COPE grant, the $1 million that grant brings for the next 3 years, how does that fit into this discussion regarding the Dix Crisis Center, the 23-hour bed facility, the continuum of care, all those things? Connect the dots for me.
There's a couple things that the COPE grant will do. The first thing is, obviously, is that we will be contracting in the next week or so with RI to provide 2 peer navigators that will work with folks coming out of the emergency room, folks coming out of the crisis center, to follow those and do case management. Now that's one of the pieces. The second piece, I think that is going to be very unique. We're going to be providing services in the school. We're going to identify folks who are overdosed, their children, getting them treatment, and also providing some preventive services inside the school, so that when folks when their parents overdose, we can identify those folks, get them into treatment, and hopefully help those children who are being so affected by the opioid crisis. One of the things that we saw is the increase in child abuse and neglect, the increase in foster children, and I think that we're going to have some impact on that when we're dealing with those folks. And I think the third phase is that we're also going to be looking at all those overdoses. We're going to be doing similar to the child fatality review team, where they bring disciplines together to look at any child fatality. When we have an overdose, what we're going to be looking at is what those factors are and how we can look at those factors and help, hopefully, impact that in the prevention mode or a treatment mode, whatever it may need. But taking all of those overdoses that we're responding to right now and try to focus on those. So it's a pretty comprehensive program, and we're excited about the piece from the children, because there's not a lot of communities that are doing that right now. But we think that's an effective piece that's going to pay dividends in the next 20 years. Yeah. So those are the MOUs that'll be signed in just a few minutes, and then of course the contracts are being processed by the city right now, and that's cooperative between the city and the county, the school system, the Dix Crisis Center, and I think it's a model people can really identify with.
Thank you.
I would add also to what Chief has said that we have, between the city and the county and several other partners, we've received well over $4 million worth of grants in our community in the last couple of years, largely designed to combat the opioid and mental health crisis. And if you need a grant for something and you can't find it, Chief will find it for you. I promise, he can find it. But we've had great success working collaboratively on this process. One of our initial very small grants that seemed to be, just the tip of the iceberg, if you will, on the way to start something, was a grant through the School of Government and Blue Cross Blue Shield to create a strategic plan to combat the opioid crisis. And we have our coordinator here today. Sophia Hayes is in audience. Sophia is the person who sort of makes sure we all meet when we're supposed to, and that we have all our stuff in order, and she helps keep our data.
She's the COPE coordinator.
And she's also going to be the COPE coordinator for this grant that Chief was just talking about. It's one more example of how your city and county are working together to combat this problem. We can't do it in a vacuum, and none of the folks who are using stop at the city limits or at the county line, and they're all running amok in between all of our boundaries. So we have to work together on this, and the Department of Justice, from whom we've gotten a lot of our grant funds, is super excited that our coordinator for this project continues from the previous project, and we've pulled these partners together and are continuing this process. And Sophia and the group that she's creating will also run the review committee for the task force for fatalities that the chief mentioned. So as we talk about the continuum, we are sort of marrying all of these pieces, the continuum of care, the continuum of our process, the continued collaboration. We're trying to keep all of this on track and keep it all together so that we are spending our energy moving in the same direction. And I can tell you from times when that wasn't the case, we're making a lot more traction these days in accessing the funds, finding the funds, and getting the partners at the table to work together. So I just want to say, you know, the working relationship is great, and the traction that we're making because of that is fantastic. And that's because of the support that both of our boards have given us to work on this together.
I'm certainly glad to see that there's a multifaceted approach being used here, because I come from a law enforcement background as well as some of the other fellows sitting up here. And, you know, we were always looking at it from the enforcement end, and that was just a matter of, it's just running in place was basically all we were doing. This is not, we're not the only ones with this problem. To be sure, we have success stories in other places where maybe there's been some daylight seen here. Do you know of any of these types of success stories where maybe a different approach was used, or?
Well, and I think that's kind of why we, and I appreciate Jack and Hope being here tonight, because I think that's kind of why we contracted with them to kind of look at where our gaps in services are, because and we've also, part of the COPE grant is a contract with an academic institute that's going to provide evaluations for us. So we can do exactly what you're asking, is see how successful we are, measure what we're accomplishing, and hopefully, but I can tell you, after sitting on the Attorney General's opioid task force, that seeing what's being done across our state, we are right on top of a lot of the things that we're doing statewide. You know, we have the LEADS program, the QRT program, with the Dix Crisis Center opening, hopefully the 23-hour facility fairly soon, and some of these other initiatives with the COPE grant, I think, are really moving us forward.
Not to take up too much time, but seeing how this is being televised on G10, there's a lot of people that are probably not aware of some of the how deep the situation is within our community. Tell us a little bit about how many overdose deaths have we had in Jacksonville and Onslow County over the last few years?
Well, I do know that within 4 months, from January 1st to April the 19th, in Onslow County, we had 8 deaths, opioid-related deaths, and 4 of those were in the city, 4 of those were outside the city, in just that 4-month period in 2019. And, you know, we had more deaths from opioids than we did homicides, fatal car crashes, and suicides combined last year.
How many calls your officers responded to where they had to administer Narcan?
In that same 4-month period, we, the Jacksonville, well, I say the Jacksonville Police Department, but it's kind of a combination between the police department and fire department. Right. We administered Narcan 80 times within the city limits in that 4-month period.
These are people that were basically brought back from the dead.
Yeah, I know that we did one person 4 times in one week.
Well, I can tell you,
1 week.
I can tell you, my wife, she's a counselor. She had one of her clients' son die. He was 29 years old last week of an opioid overdose, and the majority of her clients are people that are addicted and that have mental health problems as well. So it's there. It's definitely there. It's in our backyard. And like him, I too, you know, I was from the enforcement side, but when you see the other side and the treatment that's needed and the things that need to be done to fix this problem, you know, we do have a crisis, period. And we need to address it now before it even goes any further. So I'm hoping that the opioid overdoses drop or decline because of some of the treatment things that we're doing and some of the facilities that we have up and running, but that's a difficult task.
I think Sherry was spot on with what she said a moment ago about this being a community problem, and it requires a community solution. And it's not just us people that's sitting around this table who are going to be able to do anything about it. It's going to be a lot of folks, the faith community, parents, educators, just a litany list of people, that are going to have to involve themselves and realize that there is a problem, that something has to be done with it.
And that's what bothers me too, because like you said, Sammy, I mean, I got here in 1990, and the first case I did was a heroin case. And heroin's always been around. And it's gotten to the point, like especially in Wilmington, it's gotten to the point where it just escalated, it's starting to seep into other different socioeconomic backgrounds that people weren't aware that it was happening, and then people are dying from it. And, we let this go untouched for so long. And, so we're the ones to blame for this because we just let it go. We didn't recognize the problem when we had it because the problem's been here for the longest time. But at least we're taking a step now to do something as a community, not just law enforcement or educators, teachers, or medical professionals, but everybody, to include, county level government officials, city officials, whatever it might be. Everybody needs to get involved. Even the next door neighbor needs to get involved and do whatever they can, because it's here, it's been here, and now we're starting to see it explode a little bit. But hopefully it'll settle down, I hope.
You mentioned the deaths related to it, but we haven't, and I think we're going to hit that point, but is the collateral damage from the abuse, the death, right into the home of the children, and how it expands out from there. And I think that it's great that the educators are here as well, because I think it's the individual in your face, this is happening right now, but so often we don't see the collateral damage that's taking place in the home. So I think that's got to be a huge part of it.
You mentioned early on that a lot of jurisdictions is looking at what we're doing here with our crisis center. And I'm really happy that other communities are looking at it. But what pleases me the most is our crisis center is making a difference, and now we're moving one step at a time to get to a point that we can try to address these problems with substance abuse and mental illness and all the things that come with that, and all the residual things that happen with it too. So I'm really pleased that we got a grant, and I'm really pleased that we are moving forward with basically a triage to get people in and get them out as quick as we can. But if we can't, we can put them in the 7-day facility, and then we can decide later after that if they need to go to some type of long-term treatment. And that's what it's all about. So I commend the staff for putting the grant together and getting this one more step that we're closer. It's nowhere near solving the problem, but we're a heck of a lot better off than we were before we started this program to address this. So thank you.
Thank you.
One of the key things that I want to say too is that one piece that we missed is the education of our officers. And we've already had to the sheriff and the chief has been very instrumental with Teresa White, Lieutenant White, who's left the police department, come over to the college. The college has been a big part of this with the CIT training and with our medical first aid to get our officers all trained up to take care of getting them off the street quicker, which is this crisis center is out of this world. It's something we had to have. It's something that came into play. But all the training of these officers took place at the college through chief and the sheriff, and it's chief's instructors that have been helping us at the college to run the CIT training through Trillium is where it comes from. Yeah. But I want to make sure that we don't forget that we trained all our officers up to get them to the point to where they know what they have to do when they get them to the crisis center. And I want to thank chief and the sheriff for that. But the chief's lieutenant, who's over with us at the college now, is still teaching for us, I would believe, chief. I think she's going to do that. We've trained almost all the officers in Onslow County.
If I may say something on that, Commissioner Buchanan, from work we do in what's called deflection and pre-arrest diversion, so you heard the sheriff mention something on that. We know that if you train your officers on issues of mental health, issues of substance use disorder, they will demand the services. You know what I mean by that? They'll have someone in custody and they'll say, I now need this service. So in a way, what you're doing is you're creating natural demand. In the United States, there's about 56 million encounters between law enforcement and citizens and residents every year. About 44 million of those don't go to jail. In other words, we're going to exclude the ones that go to jail. The way we like to talk about it in the field of deflection is that's 44 million opportunities, exactly to what you're saying, that those encounters can be turned into opportunities to effectively have police say, I want this person to have treatment, I want this person to have mental health services, and the officers begin to demand it when they're trained on it. So it's a really good point. And I say this humorously, be careful of what you're creating, because they're going to come to you and say, hey, you trained me on how to do this. Now let me have the service that I can see with my own eyes this person needs. Let me have that. So I say that humorously. It's a good thing, but yes, they might be here next week.
I have a question for the audience. How many in here have CPR training?
Yeah.
How many know how to use Narcan? Not many. Jack, go ahead and finish up on that.
When we went to Charlotte to this summit for our president, and Dr. Ben Carson, the Surgeon General, was there, and he asked that question. And the audience, just about 90% of them were raising their hand with CPR. Yeah. And when the Surgeon General said, how many people here have had training or know how to use Narcan? Yeah. There was like 2 or 3. Tim was there. Mike was there, Paul was there. And then he reached in his pocket and he pulled out like a nasal spray and he said, this is all there is to it. And he said, I don't know why people don't get training, so I told our manager to start a process to get our people trained to administer that spray bottle, because you can save a person's life in 2 or 3 minutes, where if you had to call rescue and you didn't have that, they could lose their life because they don't have Narcan if they got overdose. So that's just one thing that we're trying to look at to see what kind of training is involved in that and see how much those spray bottles are. And they're really inexpensive, I understand.
I think Julie looked it up, and I think it was $3. It's not very much for one dosage, but
If you can save a person's life with a $3 bottle of nose spray, that's just one other piece of the puzzle that we're trying to look at to help address the problem.
I wanted to say something on what Commissioner Foster said too. You heard me kind of sprinkle in the testimony about children and families. It is absolutely correct, again, based on the research, that children who are growing up in homes where addiction is an issue, that includes alcohol addiction is an issue, can be subject to trauma that will impact them for good periods of their life, possibly. And there's also an intergenerational nature of addiction that has a genetic link, that has an environmental link. So when, I know when Chief Unero said we're looking at it 20 years down the road for the benefit, that's not just verbiage. That is based on the research. That stopping that intergenerational link includes providing treatment, say, to the mother or the father, whatever it is, because the children begin to normalize addictive behaviors and the trauma and the silence and the stigma that goes with it. So you are doing something very seriously for your families, for your children in your community at that point. When you are interceding on the addiction of the adult or whoever it is, you are also in a way, not clinically, Sherry will get mad at me for saying this, you are treating the family. I'll let you take it from there if you want. You're treating the family and stopping something for the future. That's a really powerful part of this too, that we often talk about the individual, the acute incident, but it is the family and children who will pay the price down the road if there's no intercession. That we know. You can bank on that one.
You're exactly correct, and for the commissioners in particular, they've heard me say recently that we've spent a good deal of money and time, which are real things for us, as well as have had a higher number of children in foster care in recent years than ever in our history in this county. Many of those cases related to the opioid epidemic, and just as a part of that, 20 years ago when I was a CPS worker myself, we dealt with a lot of marijuana use and alcoholism, and those were things where if we had to put children in foster care because of those effects, we had a shot at working with that family and getting those children back home with some treatments in the community. Opioids are a whole different animal, and the likelihood that we get children returned to a home where opioid was abuse was the reason for their removal is very, very low. And so children are forever removed from those homes in many cases, and that means that they spend more time in our system than they need to. And unfortunately, that is never the best outcome for kids. It might be better than where they are at the moment, but it's not the best outcome. And so we need to do anything we can to intercede before it gets to that point.
Mr. Lazar, you have one thing, and then we're going to move on to the signing of the.
This is a question for Jack. Since we're getting into this case management now a little deeper, what do you say, what should good case management look like? What should a good case manager do? How long do they follow the person? How long is the recommendation? And how do we build data upon the success or failure rate of that?
We are recommending 1 year of case management. It is kind of like when I said earlier around how long does someone have medication-assisted treatment? It's an individual thing. We don't know. Some people might need 3 months. Some people might need 3 years. We're recommending a year because you don't have it now, so it.
Totally.
So that's the answer on the time frame. What does good case management looks like? It's based on outcomes that assist the person in doing two things. This is all the research says. And case management is kind of like supersizing. You go to McDonald's and you order a meal, and then you supersize it. You know, that's kind of what it does. It takes your treatment, it takes your crisis center, it takes your 23-hour center, it takes your officer's interventions, and it supersizes it by binding it together. So good case management looks like this. A person is able to get into treatment very quickly, and when they disengage from treatment, they're able to re-engage quickly. And that's usually a case manager who is coming alongside them and motivating them and supporting them. That case manager also helps them get to the right type of treatment and right level of medication-assisted treatment, so they're working with them to kind of navigate the system. Case managers also speak back to people like Sherry in her role and say, hey, here's what we're seeing out there. This is what we do not have enough of. They're advocates for it. So in the outcome sense, they're helping people get into recovery faster and stay in recovery longer. That's a very simple outcome. And Sherry, you can, if you want to put more clinical face on that, you can. From a systems perspective, like what does the system look at? You should see when you have case management in place, you should see more people coming through whatever your intervention points are, the 23-hour center, the ERED, the crisis center, or just officer encounters or family encounters, more people doing well faster and requiring less critical resources in the longer run. Does that answer your question? Yeah.
I just want to ensure that, because, we work closely with this, we want to ensure that the case managers are effectively placing to the next level of care.
Absolutely.
Whether it's outpatient follow-up on, because oftentimes we talk about different agencies, they may have an appointment for the next agency, but that appointment may be 3 weeks out, and we know how critical those 3 weeks may be. So who's in contact with them during those 3 weeks, and how do we make that a success rate rather than a failure rate? And same thing, if they're going to a long-term care, what is that gap? Is that a day, 2 days, or immediate? And who follows up to ensure that they actually make it to where we're taking them? And then for the chief and I and several others in here, we're data-driven, so we want to know the success and failure rates of those things so that we can properly see where our gaps are and how we're performing and what we need to do to change that.
There are absolutely metrics that exist for good case management. CARF standards, some of you are familiar with CARF standards. You can look at the metrics to measure it. So data-driven decision-making absolutely makes sense to add in as part of this when you get your case managers going. Sherry, I don't know if you wanted to correct any of my statements on case management.
Yeah, I mean, for us, we know that this system is, our system is not the easiest to use, and that's no fault of anyone here. We are making great strides in that regard. As you heard Grace reference the no wrong door, that's definitely our plan, is that there's no wrong door wherever you show up in this continuum. The continuum will get you to the right place. And so for folks, if you think about this system and it not being all that easy to work, think about trying to work it when you're not making good decisions anyway because your decision making is impaired. You're not used to having people do anything or meet your needs anyway, so you're not expecting it. You're likely to forget you want it 5 minutes from now when you find somebody on the street who's got what you're looking for. There are so many things in place to trip this population up. And so the case manager's job is sort of to be that true north for them and keep them on track and remind them what they said yesterday when they wanted help and what's available for them and to access and advocate on their behalf to get them to that service. You heard Hope talk about a good bit of our capacity for treatment in the community is not being utilized. People don't know what's out there. They don't know what's there. They don't know how to get it. They don't know how to pay for it. They don't have insurance. And so the case managers, we'll know what services are available, how to access them, and who can get what service based on what payer source is available. And if we're able to set up some scholarships, as we were talking about, has been referenced here today from our meeting the other day, the case manager will know when they can access those and how to do that for this person, because this person's not going to know that there's scholarships out there. And so the case manager is that person who acts, as much as the patient allows them to, or the consumer allows them to, on their behalf, to connect with those things, and is there when if they fall off and they come back, it's the person that can call and say, I don't even know where I need to be, tell me how to get back on track. And that's the person that can pick up and help them do that.
In the interest of time, I'd like to have a motion from the Board of Commissioners. I'll read the motion for the record. The motion would be to approval of the agreement between Onslow County and the City of Jacksonville for the provision of the COAP coordinator as an element of the 2019 Jacksonville Comprehensive Opioid Abuse Site-Based Program, COAP grant. Can I have a motion?
So moved.
Have a second, motion and a second. Any discussion from the board? Hearing none, all in favor of the motion signify by saying aye.
Aye.
All opposed, motion carries. Thank you.
Thank you.
It's all yours, Mayor.
Thank you, Mr. Chairman. First off, I want to say thank you, Jack. Thank you, Hope, for coming and being with us tonight and providing us with the information on the Phase 3 report. At this time, I'll entertain a motion from a council member for approval of the agreement between Onslow County and the City of Jacksonville for provision of the COPE coordinator as an element of the 2019 Jacksonville Comprehensive Opioid Abuse Site-Based Program grant.
Move approval?
Discussion? Hearing none, all in favor signify by saying aye. Aye. All opposed? Next, council, I'm entertaining a motion to approve the agreement between the Onslow County Board of Education and the City of Jacksonville for the provision of school-based counselor as an element of the 2019 Jacksonville Comprehensive Opioid Abuse Site-Based Program grant.
So moved.
And a second. Any discussion? All in favor signify by saying aye.
Aye.
All opposed? Okay, so now we have an official signing. Do you want to make that part of the agreement? Clerks? Or
I think it'd be appropriate for you to adjourn and then have the school board, the county commission, and the city council representative sign officially.
is that how you want to do it?
I entertain a motion
So
to
moved.
adjourn. Second. All in favor?
Aye.
All opposed? We are adjourned.
Council, good with that?
So moved.
Yes.
You're speaking for me.
You good with that?